Welcome to our community. I'm Michael Levy, President of the Digital Health Institute for Transformation, or DHIT for short. We've teamed up with Crowdicity and the Assist Center at North Carolina State University to launch this exciting virtual incubator. COVID-19 has created a worldwide crisis that has shaken our communities to the core. The virus's toll on human life and our standard of life cannot be overstated. However, the present crisis creates an opportunity. We can come together as innovators to create new solutions that solve real problems, not only related to COVID-19, but which can be sustained long after the pandemic. We're all in this together, and we need your ideas, your input, and your energy. We need status quo challengers, those with great ideas, potential game-changing solutions, and practicing care providers and public health officials to help us submit, comment, vote, test, and develop. I'll turn things over to my co-host Adam Curry to invite you to participate in our challenges.
Thank you, Michael. I'm Adam Curry, Innovation Ecosystem Director at the Assist Center. We've worked with thought leaders in healthcare, research, and industry to identify some of the key health challenges facing us in light of COVID-19. Through this incubator, we are presenting these challenges to the innovator community. We want all of you innovators to submit and share your ideas for solving these problems, and we want everyone, inventors, entrepreneurs, people in large companies and small companies, those giving care and those who've received care, to provide your insights on the ideas you see posted. You'll find all of the challenges presented on the welcome page. Click on Challenge to learn more and post your idea about how to address it. Also, take a chance to review the other submitted ideas and provide your own insights. You may see a chance to collaborate with someone else in the community. If so, reach out and have a deeper discussion. As we move toward the end of the incubator, we'll invite final proposals, which you can submit as an individual or maybe as a team that you've formed. And our judges panel will select the most promising proposals to move on. Now, if you're in a company or other organization with an interest in improving healthcare, we are actively seeking people like you to partner with us in this initiative. Join us as a program champion, and you can issue sub-challenges to help your organization find the right solutions. Or be an innovation champion and create an innovation award for an idea that stands above the rest. Finally, you can join us as a program supporter and let the community know that you're with us in fighting persistent healthcare challenges. Over the course of the incubator, we'll also be hosting a webinar series to inform the challenges. I'll turn it back over to Michael now to tell you more about it.
Thank you, Adam. To spark discussion and catalyze ideas to these challenges, we're hosting a series of webinars every 2 weeks that bring together subject matter experts and thought leaders to educate the ecosystem regarding the many challenges and opportunities to advance care and utilize emerging technologies. The combination of these didactic expert panels and the crowdsourcing of ideas through the incubator create an engine to propel innovations from ideation to development to impact. Upon final submission of your ideas, our ecosystem of experts and champions will review them and select winners and recipients to our challenges and special innovation awards. Here's to building a cloud community to drive ground immunity.
Welcome panelists, welcome attendees. Welcome wherever you are. Good morning, good afternoon, good evening to all parts of our country, all parts of our world. Welcome to another episode of the DHIT Frequency, brought to you by the Digital Health Institute for Transformation in partnership with the Assist Center in our season right now focused on COVID uniting us all. I'm Michael Levy, your co-host for today, DHIT's president. I'm here with co-host Adam Curry, Innovation Ecosystem Director for the Assist Center. Adam, you know, we've got an incredible panel today. I'm super excited, not just for the individuals that we have today, but for the topic that we are focused on, big data and determinants of health. Naturally, this really kind of ties together much of our previous episodes around remote monitoring. Super excited. I'm sure you are as well.
Yeah, absolutely. You're right. You know, we've had these, different topics along the way. We have pulmonary and cardiac monitoring, different technologies for that. Looking at COVID and how we detect and diagnose that. We've had biochemical sensing, But what's interesting is for all those, whether we're looking at an individual's longitudinal health data, generating large amounts of data that we couldn't otherwise, or aggregate data from large populations, we're in the realm of big data. We hear a lot about it. So excited to talk about that today with our panelists.
That's right. And building on that and kind of touched on the second part of the title here, Determinants of Health. It's something that we haven't really spoken a ton about in previous episodes as we've been really focused on this data collection narrative around the utilization of remote monitoring tools from to look at pulmonary monitoring and cardiac monitoring, like you said. But determinants of health, what is that? What does that really mean? And what are we really, searching for when we think about, the day in the life of an individual? What drives what? What is the equation of health and wellness, disease and sickness, et cetera, et cetera? So as we peel this onion back, so to speak, on this episode in this session, we'll be trying to tie the technical components of big data and the realities around all of this data that exists in our life to what a picture of life and living looks like for an individual, and how that translates and correlates to prevention, prescriptive, preventative, precision medicine, et cetera. So, super excited about this session.
Yeah, and we've got a great panel for this, Michael. We've got Dr. Eric Eskioglu from Novant Health, Executive Vice President and Chief Medical Officer there. Gul Ege, Senior Director of Applied Analytics from the SAS Institute. And we have Brian Carter, Senior Vice President of Product from Validic. So we'll hear a little bit more from each of these individuals about the work that they're doing, but really tied into data and how we drive transformative applications across the healthcare systems with it. So really looking forward to it.
Yeah, thanks for the introductions, Adam. And before we kick off our discussion, naturally, like I do each and every episode, specifically paying respect and honoring our realities today with COVID and this pandemic. I'd like to send our thoughts and energy out to all of those on the front line, fighting to save lives, those who are fighting for their life, and those who are fighting to maintain some level of standard of living through the very tough realities that have come to be our norm right now, as we're facing yet another, it seems, surge in this pandemic. So again, DHIT, Assist, our panelists, all of our audience, let's collectively send that energy out into the world with positive thoughts and appreciation for those who are perhaps much less fortunate than we are today. With that, I'd also like to thank our sponsors, our supporting partners for our COVID Unites series and our virtual incubator.
Thank you to our sponsors. Thank you to our program champion, Pfizer Digital, and to all of our innovation champions. Thank you for making this possible.
Well, one note before we jump in, as we do each week, we welcome participation from the audience. There's a Q&A section in Zoom, so feel free to add those questions you have, and we will try to bring those to our panelists toward the end of the session. So to start off the conversation, Eric, wanted to hear a little bit about how Novant is dealing with COVID, especially in terms of big data at a population level. I'm sure you're paying attention to the data that are coming in, the models, the predictions. Are the ones coming in externally sufficient, or are you also maybe even running your own models or doing your own kind of analytics of what you're seeing?
Yeah, good morning, good afternoon, and good evening to everybody. Michael and Adam, thank you for having me with the rest of the distinguished panel. Really appreciate being here. So at Novant Health, we realized that COVID-19 was going to be a big issue for us and the rest of the country starting in early February. So we were a little bit ahead of the game for ourselves. And I'd be amiss if I didn't give a big shout out to my co-collaborator and what I call my co-conspirator, Angela Yoakum, who's our Chief Digital and Technology Officer. And without her, I wouldn't be discussing all of this stuff. Her and I work very closely together. And so the data analytics, we started this journey at Novant Health about 2 years ago. We realized that we had a lot of unlocked data, unlocked analytics, and we formed these teams that are on data side as well as the analytics side. And when COVID-19 started, we used actually Power BI for our data analytics, and we started getting onto Microsoft Teams. So we formed a COVID dashboard on Microsoft Teams. We quickly realized that the national data and analytics we were getting was not down to the level we needed to see at our communities. We were getting North Carolina data and maybe a little bit of Charlotte or Winston-Salem, but not deep down to even the zip codes or looking at different demographics within our communities. And so we formed a COVID-19 dashboard, and this dashboard includes actually each of our hospitals. And we look at, we were very aggressive with testing early on, and we still are. And so we have the testing results on there. We have, it's an active dashboard that updates every hour. And we can look at how many patients we have in each hospital and where they're located in the hospital. Are they intubated on the COVID-19? What are our resources for that? And we also have a couple of other dashboards that looks at the positivity rate for the tests we're performing in the community, as well as our admission rates. And we try to predict, where the, unfortunately the puck is going, and are we going to have more increases? What's been interesting is, even though we are in mid-Atlantic region, and you would think that that's a small region, compared to the rest of the world, we've seen big differences in our markets, even 50 miles away or 100 miles away. As one market has been going up in COVID patients, the other market has been going down. It's been a seesaw going back and forth. One of the other things that have helped us out is we also looked at the supply and chain side. As you know, the PPEs and ventilators have been a big problem. So we also developed a dashboard that gives us a live analysis of, at any given time, what percentage of our ventilators are available at Novant Health, what percentage of our ICU beds are available, and you can get down to a system level, look up from the 50,000, you can get down to each individual hospital. That has allowed us, and pharmaceuticals as well, that has allowed us in the system to be able to shift our resources as we see areas where things are getting hot, and shift the resources so we don't have to, rush in and trying to buy things at different locations at different times. And it's been very helpful. I think the thing we're unlocking right now is the social determinants, and we're looking at each population. Now, I'm proud to say, we've all heard that populations that had disadvantaged populations, like the migrant communities and also minority populations who have food insecurity, primary care physician insecurity, transportation insecurity, housing insecurity, you name it, that they are hit indiscriminately and a lot harder on COVID-19. I'm proud to say that the first thing we did was we really started doing testing in those communities. We were the first to get into those communities in our markets we serve, and our relative risk of death for the African-American population is actually 0.76, which is lower than the rest of our population, which part of the reason is their age group seems to be younger in our service area. So we have about a 62, whereas the rest of the white population has about 67. And so we started diving in and looking at each population's, each community's determinants as far as what kind of comorbidities they have, what kind of other cofactors. And this is all work in progress. And as you know, with COVID-19, we're still learning so much, and there's still so many unknowns. So, we're still trying to decipher the data, and I'm sure we're going to come up with some better predictive modeling, because our goal is to identify people who are at high risk. And we know high risk in general, people over 65 who have other comorbidities such as COPD, heart disease, type 1 diabetes, obesity. But we want to get down to even more, individual risk factors that are going to affect these patients. And, we've heard about O blood type, they're less likely to get infected. We heard that men are, unfortunately, I'm in that group, men are more likely to get infected and have worse outcomes. So we want to get down with the data analytics to all of that.
Yeah, well, that's fascinating and really cool. I gotta ask, is this built on something that existed before? And do you see it being applied in ways to do things that you weren't able to before going forward after COVID?
Well, let me start out by saying that COVID-19, as unfortunate as it has been, as tragic it has been, it is transforming and continues to transform healthcare in 3 months that we have not been able to do in 15 years. So I think that's the silver lining to look at after all of this. And we were fortunate enough, like I said, our CEO and our board and our executive team had the vision to get into data and analytics before any of this hit us. We were already in it. We had moved our Epic data to cloud, which really helped us do a lot of artificial intelligence type of work. And so our teams were ready. So for us, we already had a lot of data and analytics capabilities for institutes. Our Chief Safety and Quality Officer, who is our face of our COVID program, is also an infectious disease expert, Dr. David Priest. So we were already ready for this, and this accelerated it. And we're seeing a lot of acceleration of the data and analytics that we wouldn't have seen normally, and a lot of buy-in from our team members, and they're starting to see the value of this. And coming out, we're going to be judged in more how we come out of COVID-19 than how we enter into COVID-19. So that's the important point we're trying to make.
Yeah, that's awesome. Well, Brian, wanted to come over to you with Validic. So Validic's been bringing in health data from the individual, a lot of different data streams. Wondering how you're thinking about this, maybe especially in the context of COVID, but you've been getting that longitudinal health data for years. And so just wondering how you guys are thinking about this and what you're seeing.
Yeah, probably best to just kind of talk about a couple use cases that we've helped solve. Validic really got its start supporting entrepreneurs and I'm not a big fan of this word, but entrepreneurs like Eric and his team who even inside a health system have developed platforms where, thought forward on creating a big data platform and analytics. And, where Validic really got started was looking at this ecosystem of just the explosive number of personal health apps, devices, consumer grade medical devices. And how do you harness all of that? Every manufacturer has a different specification, a different way to get the data, a different format for the data. And, if Eric's team wanted to tap into pulse oximeters and, especially during the COVID crisis, the availability of any specific brand of pulse oximeters was not very reliable. That would be a massive amount of work to go try to tap into all of those different sources. And so, since 2012, Validic has been helping organizations tap into those ecosystems. And so, even before the COVID pandemic and the health system side of things, one of the things that we've seen some progressive organizations do are things like pre and post surgical prehab and rehab. So even if you think about just activity trackers, if somebody's coming in for a knee replacement, what was their level of activity before the procedure? It's probably going to go to 0 the day after the procedure, but then we want to see them continue to progress and eventually get to a higher level of function than they were before. And so we have clients that have done things like that with our data connectivity platform, but what we've seen, unfortunately, is a lot of organizations do not have the technical capabilities or the capacity to go do the types of things that an organization like Novant has done. And so what we really started to hear probably about 3 years ago was, it's great that you can get me all this data, but if all I can do is dump it into my EHR, the EHR doesn't really know what to do with that high frequency of data, those types of observations of daily living, things like that. And so about 3 years ago, Validic really kind of pivoted towards creating an application and analytics layer that sits on top of that data connectivity platform. And that's really where a lot of our more recent focus has been. And so, when the COVID pandemic started, when the first stay-at-home orders were issued, probably about 3 weeks later, we released a complete standalone turnkey application to do COVID symptom monitoring. And what's been interesting is, initially this was conceived of as a toolkit for health systems to help monitor their patients, and that has been really successful for us. We have a different healthcare provider in the Mid-Atlantic region who is using that solution to monitor all of their diagnosed patients who are not critical enough to use up an ICU bed or even a hospital bed, but to keep track of what's happening with them on a twice a day basis, looking at their SpO2, their temperature, their symptoms surrounding their condition. And I'm going to just read a couple quotes that we got back from the providers that are using this solution. One is, good news stories from using this solution are so common that people are just not telling us about them anymore. And what they mean by that is literally on a daily basis, in thousands of patients that have been sent home with positive diagnoses, they were able to monitor their SpO2, their coughing severity, and they were able to identify people that did need to be brought back in. And they've told us that very likely through this monitoring, these patients who would have been sent home even without the monitoring tool, without the monitoring, probably would have not made it, because they were all in that category of what they're calling the happy hypoxic, who, their SpO2 is 80%, 75%, but they feel fine. And it's just one of the weird things about the disease. So, the way we were able to deploy that is because now we're not just doing data connectivity. That still exists. So an organization like Novant, who has those platforms in place, we can plug that in and they could pull all of that data in. But what we've really seen important is a lot of organizations just were kind of caught flat-footed. And so having these turnkey solutions was a pretty critical thing for them.
Thanks, Brian. Amazing stories, and congratulations on the success in providing value in a time of great need for different maturity levels of organizations. I think that's your point about and Eric, you're kind of the level set on where you are, specifically Novant, where Novant is, and where you and Angela and the team. And by the way, we had Angela on our first COVID Unites episode, so it's great to kind of bookend here with you. But it's a mature organization, but the majority of organizations from a data perspective are not there. And Validic, you guys have been really supporting that evolution for all types of healthcare organizations, all maturity levels for many years. And naturally, you've gone from the connecting and collecting of data to now really building analytical solutions to help service. So that's great to hear. Gul, you've been my kind of research on your background and work has been somewhat enlightening, and I'm walking away with this new quote unquote, instead of the Internet of Things, the analytics of things term, and it really kind of gets to the kind of heart of maturing from biometrics and physiological data sets to data across all of life, based off of all of the IoT, all of the smart objects in our world, and the ever increasing nature of that proliferation. You've been on the front lines for the analytics of things now for many years, and you're helping SAS evolve its analytical intelligence. Can you share with us, what you've seen over the last, let's say, 5 years from an analytics perspective, and then what you foresee, kind of evolving, now that we have this almost inevitable maturation of smart, connected world, and then perhaps tie that back to what you're doing for COVID.
Yes, it's really great to be here and listen to Eric and Brian. because, of course, SAS has been in big data analytics, AI, for 40 years. I've been there for most of that journey. Last 8 years or so, we have been focusing more and more in my team in IoT applications in the connected world. How to bring streaming data, how to react real time on streaming data, as well as how does the streaming data really complements and draws from what we learn from the data at rest. So in our world, it is analytics everywhere, where we're in the cloud, whether we're in the device, where we're in the gateway. I think the connected world in healthcare or any other place really goes beyond big data, goes into metadata or any other way you describe its incredible amount of data that's created from sensors, audio data, video data, image data, text data. And I think many of the analytical teams or analytical challenges remain consistent across, to some extent, across many domains. One of them is in this high frequency, high volume data, there's incredible amount of noise, especially when you go to like wearables or things that are moving. So denoising algorithms also very important, because otherwise, if you react to noise in these sensors, basically you could mislead. And of course, in especially the medical field, that is not an acceptable level of accuracy. So denoising algorithms seems to be the first step always. The next question is, how much of this data, enormous amounts of data being generated, is really meaningful to keep for further analysis? So we do a lot of work in data and dimension reduction. So we keep the valuable insights or meaningful nuggets from this data without having to carry all of this to the cloud, which is neither needed nor necessary. It's there's not enough cloud in the world to keep all the data being generated in the world. I think the next things that we focus on the data that's being generated, it's when we need real-time reactions. So we want to catch anomalies as they're happening and alert somebody or some system to make the correction. And those are specific anomaly detection algorithms from almost every field coming through. And the other one is to be able to quickly use a classification model. The one that's coming up a lot is from recently, of course, with COVID. Can we, from audio data, detect and classify a cough? Is it asthma cough? Is it dry cough? Which I guess COVID implies. Is it a wet cough? It sounds terrible, by the way, when you keep listening to it. And what do I do about it? But this goes hand in hand with, once we do, these need to be compared to rule-based alerts, needs to be pretty accurate, and we shouldn't be over-alarming. So we focus on both the accuracy and not creating over-alerting from these analytics on the edge. This is also goes hand in hand with machine learning models, deep learning models that are actually running on data at rest. Because whether it's the medical domain's knowledge or data, let's say we're looking for at an image of a brain scan, what that means really comes from either labeled data that or patterns that medical domain has captured, and automation of these things to give some relief to medical staff. And in a way, letting what we do on the streaming data draws from these learning models on data at rest. COVID-19 has actually brought, whether it's clinical trials, coming up with vaccines, a lot of science fields are involved right now. And our most recent, this year's SAS Global Forum had a focus track on our customers and their customers, their needs, of course, both in the short term and long term, reacting or handling the challenges of COVID-19, from Cleveland Clinic using SAS to do resource allocation or resource planning in light of predictive capabilities. Like Eric described, many people are trying to figure out, it's a very, in terms of science, it's very new data, and it's being collected continuously, and it's been, many data sources need to be put together to do the kind of mining Eric is mentioning to be done. Is there any correlation or between the age of the patient and the outcome? A zillion scenarios like that. That's what needs to be supported. But I think these were all needed. In a way, I agree very much with Eric. COVID-19 brought an enormous urgency to many of these things that needs to be now done much faster. Contact tracing, for example, when there is bandwidth problems, can network analytics help somewhat automate contact tracing is one that is coming up. In addition to health and wellness monitoring, both in inpatient and outpatient scenarios, which existed, there is now also a big focus on public health domain use cases. Can we look at not only individual movements, but the movements of a population to help predict some of the spread of COVID or anything else in the future? But these innovations will stay with us, and just like this panel and people beyond that, people from science, medical, technology, and software and analytics are working.
Yeah,
it takes everyone.
Yeah, absolutely. And I'm glad you brought up two important points. Along with many others, but two jumped out at me. One is, this longitudinal individual health data, which is very much in the realm of what you're talking about. This continuous data streams, very much, I think, in the realm of Validic, even if it's episodic a little bit. But you all made this connection between personal and public health. And Eric, as you were talking, there were a lot of public health decisions you were making. So I wanted to get your view on how valuable it would be and how you might begin to integrate this, high frequency or the availability of individual health data that maybe you're not getting now. Would there be value in that? Are you seeing that as the next wave or the next opportunity?
Yeah, absolutely, Adam. Before that, I want to actually build up on what Brian and Gul have talked about. First of all, Brian is absolutely right. Remote monitoring is going to become the norm, and touchless patient care is going to be the norm. Just imagine, why would patients, especially in this day and age, while we still don't have any vaccination or effective treatments for COVID-19, want to go to a clinic, and there's a subpopulation of patients that are going to be completely used to being virtual healthcare, and they're available and suitable for that venue. And they don't want to drive an hour back and forth to a clinic, wait 15 minutes with other patients, and risk catching COVID-19 or any other diseases. So touchless patient care, as far as remote monitoring, is here to stay. I want to build up on what Gul also said is, we need to make sure that we remove the noise from that. We don't want our physicians, our nurses, our nurse practitioners, our physician assistants getting overwhelmed with alarms. And that's going to take some time. But as we gather the data with artificial intelligence, with machine learning, and more fascinating to me, the artificial neural networks with deep learning, this is going to get better and better and better. And we're going to come to a point where, the remote monitoring is only going to alert you when it knows that there's something serious about the patient before the patient becomes ill. Now, going back to the social determinants, I want to actually, first of all, say that basic promise of democracy is equal access to healthcare. And we all know that. That is basic promise of democracy, equal access to healthcare. We've all known that there's inequities in healthcare delivery. We've known that for years. We've talked about it. But COVID-19 has really brought this to the surface. And what I mean by that is, just think about it. We're talking about, if somebody tests positive in an underserved neighborhood and we're telling them to go and isolate themselves for 14 days. If they live in a house that's 1 bedroom with 4 kids and 3 other adults, how do we isolate that person? So what we have recognized as Novant Health over the last 5, 6, 7 years, we've been really into the social determinants for a while now, is what actually affects the patients most is not what's happening within the 4 walls of our system and the hospitals and clinics, but it's outside that affects the outcomes of the patients. So we pay a lot of attention to physician insecurity. Most of these patients don't have physicians. COVID-19 is giving us an opportunity to reshape that. What I mean by that is, you've all heard our ER visits are down, right? Everybody's saying our ER visits are down, and that is true, our ER visits are down. But before this started, we used to talk about how ER is inappropriate venue of care for about 20 to 30% of the patients and how it drives up healthcare costs. We don't talk about that as much anymore. We are at Novant, we're trying to determine which are the patients that are avoiding the ER that used to use as a normal venue of care, and trying to steer them into a normal venue of care, whether it be a primary care physician or a virtual health. And so those are innovations we're looking at. As far as housing, I mentioned, isolation is a big problem. I mean, just think about somebody who doesn't even have a house. If they're living in a homeless shelter among a lot of other people, that's going to be an impetus for getting infected. We have made the conscious decision of investing in our communities. We've actually last year donated, before COVID-19, $8 million to a housing project to secure affordable housing in our communities. And we continue to invest in social determinants, because that's, as interesting as it sounds, we want people to be healthy. We want to only take care of them when they definitely need us, and we want to avoid unavoidable health problems. And so those are really important for us. And I want to build up on the fact that, we're going to get better at this. And, we need to team up with other systems, like Gul's, SAS, Brian's, Validic. These are systems that are we can't do it ourselves. A healthcare system as big as Novant, as integrated as Novant, we still look at partners to partner up and drive the value out of healthcare for patients.
I mean, so to that point, my understanding is about a year and a half, 2 years ago, you launched the Institute for Artificial Intelligence and Innovation. I would imagine that was, part of the reasoning is to create a front door to drive partnerships and collaborations. Gul, you mentioned you can't make sense of the data unless it's labeled correctly, so you need the right subject matter expertise. Obviously, you have other technical aspects that, like, Validic is providing, and so this is a really a collaborative economy and a collaborative problem set that seems to be before us versus perhaps a more competitive, individualized narrative. Is that fair to say, Eric?
It is, and our Institute of Innovation Artificial Intelligence that I'm lucky to co-lead with Angela Yoakum, we actually look at different constructs. So it's not just artificial intelligence. We look at all sorts of technology, and we bring in experts that are in that group that are part of it just for that portion and help us out. So we have multiple, it's like what you described, Michael, is exactly what we envisioned. It's an open front door, it's a construct to have multiple different things underneath it. I mean, a couple of examples I can give is zipline drone delivery. We were the first in the country to use zipline. We teamed up with Zipline, who have done a great amount of work in Africa, delivering medical supplies and pharmaceuticals and PPEs into rural areas in Rwanda for years. And we started doing that for PPEs because we want to do on-demand delivery from our centers for PPEs. We don't want to transport them by ground, and it's more efficient. Now we're looking at doing that. Just imagine, unfortunately, COVID-19 is here to stay until we find an effective vaccine. That's probably at best estimates a year and a half away, mass vaccination. And come fall, we're going to be dealing with not only COVID-19, but also with the flu. So at this point, and hopefully by fall, we will have some medications that are working for COVID-19. So we're looking at ways to deliver with drone to the patient's homes these vaccinations, not vaccinations, I'm sorry, the medications that may treat them. We're looking at patients that shouldn't leave their home. Just imagine somebody who just had chemotherapy for breast cancer, they're immunocompromised for the next couple of weeks. We don't want that patient to leave their home. We don't want them to catch any kind of thing like COVID-19. And the way we want to do it is we want to deliver their medications directly to their home, touchless, with on demand within an hour. So those are technologies we look forward to. We do team up with a lot of other technology companies, and we co-create, we team up. So we have all sorts of different constructs how we work with different companies, and we don't limit ourselves. So we're proud that we don't limit ourselves.
Yeah, you brought up something that really struck me, and I want to see if Brian has a thought about it or, response to other things maybe that you've been hearing, Brian. But looking at how we increase healthcare access, even to the point, Eric, if I understood that you would be investing in communities so that you're, improving health and environments for wellness. Brian, that sounds like maybe a natural place to begin bringing in some of these technologies that I think maybe, I would have at first look think maybe are out of reach. A lot of the smart technologies almost seem like a luxury. So wondering if that's something you guys have looked at. Could we kind of democratize care a little bit by bringing in, these remote monitoring? Anyway, just wanted to get your thoughts and playing off Eric or playing off that team.
Yeah, definitely a couple thoughts there. One, even before joining Validic, this was probably circa 2011, 2012. I worked on a pilot project in New York with a health system who was trying to address some of exactly what you're talking about. And one of the first things is we started studying how to help this population just a little bit more. It was specifically started with an endocrinologist who told us the story. They were having a conversation with one of their patients, trying to do education about low glycemic index diets and things like that. And the patient said, "Let me stop you and first tell you, most of my meals come out of a dumpster. So to talk to me about my diet right now is probably not the most useful place to start." And so, there was a whole backup and reapproach, and part of it was around just access to things that can help support treating that condition. So the health system opened a farmer's market. Like they said, we never expected that we were going to be a grocery store, but that's part of what we need to do. And so food as a prescription became a really important part of that strategy. They then, Adam, to your specific question, said, all right, remote monitoring with health devices is a great idea for these folks, just like it is for everybody else, but they don't have Wi-Fi and they don't have a place to charge up their devices and things like that. And so what they did was, and this was when I was working with Cerner, and Cerner Corporation helped do this, got them low-cost mobile phones that could support Bluetooth. They set up a safe place to recharge those devices, do battery exchanges on the glucose meter, get supplies for those devices, and really started to see a lot more effectiveness. And the other thing that that cell phone gave them was a really easy lifeline back to the health system anytime they needed help. Typically before that, they had caseworkers who literally would drive around the city trying to find the patients that they were taking care of. And now they had them all on speed dial and they could reach them anytime. So like a lot of times when I sit down with health systems and we're thinking about how do I do a remote monitoring program, everybody's thinking about monitoring people that live the same lifestyle they do. And, you know, you really have to think a lot more broadly about all of the other needs that you might not be thinking about. And so, you know, that was a very successful program. I think also with the ubiquity of 5G coming around the corner and not needing to rely on Wi-Fi as much, the continued driving down of the cost of these devices, you know, I think there's a lot of things that are going to be a lot more in reach than maybe we would have thought they were 5 years ago, but it's still going to require some structural support for these types of programs. It's not going to just be something people can go out and do on their own.
May I chime in here? And I guess some of the conditions you're bringing up, Brian, also puts a little bit more focus on some of the sensors that are coming out of the assist program on energy harvesting and all and low energy usage, even more of a need, more of an urgent need. And one other thing I want to bring up, and in the sense of community, COVID-19 has brought up is as the pandemic progresses through the world, every country, every region is in different stages. One of the things that is happening is text mining research that's coming out, as well as social media that the doctors here are interested in, what the doctors are doing. And although like we will know a lot more, and medical field will know a lot more about COVID-19 a year or two later, but the scientists, medical people are in an urgent need of what others are learning, maybe a few weeks ahead of their pattern of the spread and urgency. But so text mining is coming through as a huge need in trying to figure out what's being said in research papers coming out, and trying to, or even social media posts, of course. A very interesting use case that is coming out of scientists' needs to stay as current as possible or learn whatever else everybody else has learned around the world. So it's fast-paced knowledge gathering as you can with.
Well, to that point, you know, it kind of gets back to the noise point, and you know, and I'm gonna direct this question to Eric and pull it from audience Q&A here as we are reaching that time. But you know, what do you focus on, right? How do you go from, you know, this meta level of data to a micro level of confidence, knowing that there's so much to pay attention to? The audience question that kind of ties to this is, you know, how does Novant specifically identify which social determinants to focus on for their population? Do you have a standard process? Is it driven by, you know, analytical models that evaluate the noise and bring you insights to then sift through? You know, do you have a sense of how you're going to handle this moving forward from a process perspective? Or I'm sure you already do, but you know, the noise is going to continue to evolve and amplify. So what are your thoughts on that, Eric?
Yeah, great question, Michael. So one of the things we look at is, in our vast amount of data, we look at patients who come to the ER frequently for diseases that shouldn't be treated in the ER. and try to identify with our case managers, what is the root cause of that? Why are they coming? So we try to identify that from data analytics perspective, and trying to, communicate with the patient and trying to figure out what is their barrier to not getting primary care, and trying to set them up with that. We've seen issues with patients not showing up to their regularly scheduled wellness visits. And when we looked at it, when you call the patient and find out they have transportation insecurity, they can't afford to come. So you got to get some sort of transportation for them. So it's almost like personalized. You can't put a blanket on it. Yeah. And as we get deeper and deeper to data and analytics, we're starting to identify trends in different patient populations, even zip codes, and trying to go in and make the biggest effect. One of the things I can tell you is, we were fortunate enough to team up with Michael Jordan, who is in Charlotte, and open up Michael Jordan clinics in our underserved areas, because we noticed that those zip codes were driving a lot of the ER volume that was unnecessary and that could have been easily taken care of in a community health setup. So we have those clinics that are really serving those populations and driving down the numbers. So we can do strategic asset location and also, be able to take care of these patients in the right venue. And, this is an evolving process for us. You have to understand, like every other healthcare system, we're mostly in front of everybody else, but it's still a new journey for a lot of the healthcare systems. And, we are, expected to go better and better, and we are going to do better for our patients. One of the questions I also get asked in this venue is usually, are you using natural language processing for your physicians? And as a neurosurgeon, I'm actually, I've seen myself turn into a data entry clerk over the last 20 years. And, I've seen our nurses turn into data entry clerk. And we are testing some natural language processing, especially using artificial intelligence, where the patient and the doctor are conversing, and that natural language processing takes all that information, turns into a note. So I'm not, standing my back to the patient and typing away data and maybe half listening to the patient. So those are going to be, again, going back to Brian and Gul, those are going to be things that keep evolving and get better. Hopefully we'll all be around in 5 years to discuss this and look back at the COVID-19 and what it did, and we're going to be amazed. I mean, I'm actually very hopeful for the future once we defeat this menace.
Yeah, thanks, Eric. So Adam, maybe pull a question from the audience if you have one in mind. If not, I can jump in.
Yeah. This almost seems like an acknowledgement of an opportunity, but I'd love to maybe hear some thoughts. And I think this does go to you, Eric, but other thoughts may come in. Just the idea that the remote nature of care, reducing the potential, at least, for hospital, infections or transmission within healthcare settings. Maybe the question is that something you think about?
Yeah, of course. Obviously, while we're dealing with COVID-19, we can't lose focus on the safety and quality of our care at our acute care facilities, at our clinics, because that's really vital. So we have to balance both of them out. As we're taking care of COVID-19 patients, we still got a whole bunch of patients with other healthcare problems that need our attention. So, the more we can have patients not needing to come to the hospital, the better we're off. If we can treat them at their home, and that's where, all the touchless care, all the artificial intelligence, all the remote monitoring is going to head, the less we have contact point with the patient, accurately take care of those patients, the better we're going to be. Now, I got to give you a word of caution. Telemedicine took off. We all talk about telemedicine. It's as if the panacea. And when we shut down in early April as a system, as an integrated 14 hospital, 650 clinic system, it was a shock to our system. The year before, we had only done 152 e-visits, ambulatory e-visits. And at the height of COVID-19, we were doing 7,000 e-visits a day. Okay, just 7,000, just think about that. And we're still continuing to do a vast amount of e-visits because, as I told you, there's a certain percent of the population that all of a sudden realize this is the way to do it. And if I don't have to go to the clinic, I'm all for this. The problem with that is we need a method of sorting out these e-visits. And this is where, again, Gul, I think your expertise is going to come in, and the people who work in artificial intelligence community. How do we sort out televisits so we direct the patient to appropriate venue of care? Do they need to be, are they appropriate for a clinical visit on a telemedicine? Do they need to come in person to the clinic? Do they need to go to an emergency center? Or do they need to go to an urgent care center? And so what I call the triaging of telemedicine hasn't happened yet, but it will over the next evolving couple of months and years. And you'll see a little bit more differentiation how we use telemedicine. It's not panacea. It's not going to solve all our problems, but it's here to stay, and it will continue to evolve as we evolve with it.
I'm very thankful, actually, being offered as a patient, being offered a telemedicine opportunity, both in like physical therapy, where I don't have to drive anywhere, I don't have to be among other people anywhere. It's been working very well, or more of a routine touch base with your GI doctor, for example. So building that, how do you sort those out is great, but that's one thing that I think patient population is probably enjoying the convenience when appropriate of it. But yes, how do you sort it out so that what is appropriate gets ironed out without too much, taking too much medical staff's time? Yeah, I liked telemedicine, really. It's one of...
I can tell you, my wife used it for our kids, and I don't know if she'll go back to wellness checks, because we also use TytoCare. So we can actually monitor the patients. You can do the exam at home. And she used it, and she's like, I don't know if I would take them back unless they're really sick and they have to be seen by the pediatrician. And so, but you know, on the caution side, there are types of patients. If you're having chest pain, that's not somebody you should see on television. And I think those are things that we're looking at. One of the things I get asked a lot is, you know, what do you do with the data? How do you provide protect the patient's confidentiality? We have a great chief data officer, Carl Hightower, and our data gets de-identified. And we learned from unfortunate mistakes of some of the other healthcare systems that have been in the news. And we are really, really cautious about protecting our patients' data, because your data is like your DNA, and none two are alike. And we want to make sure that we protect it. We de-identify it so it helps the rest of our population, but never use your data in any other setting. Yeah, individually.
Absolutely.
Brian, to that point, you know, obviously Validic's serving a number of clients. Dealing with data. So there's an added risk, an added level of security, compliance, privacy, protection that I'm sure, you know, keeps the team at Validic, you know, up at, perhaps not up at night, but fueled to solve against. You know, is that common, de-identifying data? Is that the way you handle it? Are there other techniques? You know, what are you providing for your systems, and what are the variations too?
Yeah, what I tell people to look for in any company that they might be looking to work with for patient-generated health data aggregation, some common patterns that you want to be looking for is, are they, one, logically isolating each of their clients' data from each other? That's a first hallmark that tells you whether that company is secretly behind the scenes building a graph of everybody's data from across their multiple client endpoints. Like at Validic, for example, if you are a patient of 3 of Validic's clients, you exist in 3 different databases. And those data are never merged together because we're operating on behalf of the health system. The second is the de-identification. When data comes through our platform and we hand it off then downstream to our clients, we don't know who that data is about. We don't want to know who that data is about. The only way it can be rehydrated with personally identified information is by our client. They give us an identifier that doesn't mean anything to us. We don't want your medical record number. We want something different that only then can be reconnected with that patient specific entity at the endpoint where it's intended to be consumed. The third is you need to look upstream at where you're receiving the data from and the specific manufacturers of devices and what are they doing with those data, and are they going to be following the same level of standards that everybody else in the chain is? You're creating a pretty big web of interconnected points, and you do need to have somebody on your team, like Eric mentioned, that is really looking after that, but also partner with vendors that are taking that as seriously as you do.
Yeah, thanks, Brian. And I'm guessing, Gul, as we kind of close out here, maybe you can respond very quickly on SAS's, perspective on privacy, security. Obviously, this is going to evolve. The threat is increasing across the globe as it relates to finding ways to hack our systems and to drive some sort of seize around our economy and our wellness. Do you see, how much does SAS focus on privacy, security, and any closing thoughts on this topic?
Yeah, I mean, obviously, both in health and HIPAA regulations, and also in other financial, there is many security concerns from different fields. SAS does address for many years, and some of the analysis we are talking about here doesn't really need to know it's Michael or it's Gul or it's Brian at all, other than the attending doctor probably. I'm seeing one question on the Q&A that it's Michael Lim is asking. Okay. How SAS ESP, how researchers might be able to use SAS event stream processing and streaming analytics capabilities. Actually, if you look at our SAS hosts trial environment for if you want to try SAS event stream processing. And I think you can put your own data, do your own thing, stream your own stuff. I believe it's on www.sas.com, and if you go to ESP or IoT, there is a get me an environment, and you can extend this environment, Michael, and we have academics and individuals that are using these environments. Same goes with the environment SAS provides looking into COVID-19 data. We have created some of the reports, but you can do whatever else you want to do with it. So example environments are hosted, and it's yours. Nobody else is there with you. So please contact me if I can. I can help you more with that. Yeah.
Well, we're closing in. We got a couple of notes to share with the audience. First off, thank you so much, panelists. A great pleasure. Tremendous insights and perspectives shared. I hope you all enjoyed it. We certainly did. It was a very active Q&A from our audience. So thank you, audience, for participating and engaging with us. That does close out the portion of our session with our panelists. We will be following up here in 2 weeks with another session, further details to be released here middle of next week. But it's going to be focusing on the path from innovation to impact. And it'll be a two-part series under the COVID Unites Us All framework that talks about if you have a concept and you want to bring it to market, how do you move that forward and each step of the way. So stay tuned for more details. And then I guess a couple other notes. Again, thank you to our sponsors. Appreciate it. We'll get into that maybe, Adam, as we're closing in here. You could just say a note on the awards as we go and talk about the virtual incubator for a second.
Yeah, absolutely. You can see some of our great sponsors on that last slide, but all that goes into this virtual incubator that we are running. It's very exciting. We're looking at new technologies for remote health monitoring appropriately, part of the same series. If you go on the website, dhit.crowdicity.com, you can click on the challenge, some questions, and ready to apply. Very simple. Applications are due by July 24th at 5 p.m. It's a simple online application form. So we're looking for great innovations at any stage. If we go more slide, you can just see all the support that will come at the end of this. So $5,000 Program Champion Award, and then support all along the development path from very early insights into clinical relevance all the way into clinical and market validation. So great opportunity for those of you with young ideas, early stage companies. So really encourage you to go there, participate, and share that with others you know. So with that, thank you all again. Thank you, panelists. This was a great discussion. Thanks for those who have joined us. Everybody have a great day, a great weekend. Take care. We're signing off.
Cheers.